afternoon. It's In the Trenches, and I'm going to talk about a patient I just saw. Now, how I'm going to approach this. This is a 58-year-old woman who was obese with borderline diabetes, was on Mounjaro, had a history of high triglycerides. And basically, she came in the office complaining of polyuria, increased thirst, and a dry mouth. So the first thing I wanted to do was get a urine sample on her and dip it, but she just urinated, couldn't submit a sample, so we got a finger stick on her. And her finger stick was 497. So let's talk about how to handle this. What are the options? Okay, this lady is severely diabetic, and this needs to be brought down. It clearly needs to be brought down with insulin, and needs to be brought down with basal and bolus insulin. But with this, she's going to need proper diabetic education, which in the office, busy office afternoon, might be difficult. She's also fluid depleted. Now, I need to check labs on her, but I imagine her BUN creatinine and her BUN creatinine ratio are elevated. The next thing is she in DKA? She's probably not in DKA or in the beginnings of DKA. Okay? If she were in DKA versus hyperglycemic, hyperosmolar state, normally they have lower blood sugars and they have no insulin at all. What insulin does, it inhibits glycogenolysis, gluconeogenesis, increase uptake of glucose in the tissues, especially muscle, and inhibits lipolysis. Now, you need a lot less insulin to inhibit lipolysis than do the other things. So that's why often type 2 diabetics have enough insulin to inhibit this. Okay, now she's in diabetic ketoacidosis, that's an endocrine emergency. And think physiology, we talked a little bit about this. My last talk on acid base, Henderson-Hasselbalch equation. So if you have DKA, your pH is low. It means your hydrogen ion is high. You want to bring this down. To bring this down, you could either decrease your PCO2 or increase your bicarb. Those are the only ways you can do it. To decrease your PCO2, what you're going to do is hyperventilate. So these patients are short of breath because they're hyperventilating, and that may enable someone to go to the emergency room or get immediate medical care somewhere else. To generate bicarb, there's really only one way to acutely generate bicarb, and that's the vomit. Okay, it takes about 48 hours for the kidneys start working. So these people are vomiting, and they could have abdominal pain with this, and sometimes they could come in and they're in the ER and they get the surgeons down there first because they think this is an acute abdomen. But these patients are usually symptomatic. Now, sometimes very early, they may not be symptomatic. The key to treating both of these things are IV fluids and insulin. Okay, if you give a patient, this patient I decided to send out to the ER. I thought it's better, she'll get hooked on IV and they'll give her fluids. And the fluids themselves will lower her sugar. They'll dilute out the glucose. They'll increase the amount of glucose in the urine. She'll pee it out. As she gets IV fluids more going to the kidney, she will pee it out. And they'll also decrease the counter-regulatory hormones which are probably elevated, like glucagon, epinephrine, growth hormone, and cortisol. So we're gonna have her get IV fluids. She's gonna need insulin. It's gonna be tricky how much she's gonna need, but initially she's gonna need insulin. Down the line in a type 2 diabetic, maybe she could get off the insulin. There's something called glucotoxicity. So the higher your glucose is, you start releasing insulin until your sugars are real high, and then the high glucose inhibits insulin release. Once you get somebody back up on this curve, they can start releasing insulin on their own. But this patient's going to need insulin initially, and she's going to need fluids. Okay, another reason for getting her to the hospital, we need to see what her potassium is. Patients with DKA, in the olden days, they were admitted to the general floor, and sometimes these people were admitted and they would die overnight. And what would happen, you give insulin, and that would take glucose intracellular, right? And it would take potassium, and they become hypokalemic. So as she gets treated, we need to see what her potassium is, and that needs to be monitored. Now, she's probably, with HHS, often these patients can't get the water. Often when your sugar is 900, 1,000, these patients are either cognitively impaired, maybe on hyperal or TPN, or they had strokes, so they can't verbalize their symptoms, and nobody's seeing them, and the sugars gets up that high. Now this patient was totally cognitively normal, and imagine her sugar's high and it's going higher. An A1C will give the average glucose over the past 3 months. That's going to be elevated, but that's not going to change what we're going to do here. Okay, so the key with her is really to restore fluid and then to give her insulin. She'll need to be on a basal bolus regimen. And there are different ways you could do that. You could put her on an IV insulin drip, and this way you could titrate it, and you could see where the sugars are, and then you could switch her, and they've calculated software, the basal insulin, and switch her to basal bolus insulin. And they're different. They've lowered this. What I learned was your total insulin is about 6 units per kilogram. And you split it between basal and bolus, and then the bolus you kind of split 3 ways. Now they may use less, but the idea is she'd probably be on IV insulin, and then they'd get switched to short-acting insulin, like 4 times a day, and then a basal bolus regimen. The other option with her is to give her fluids, 1 or 2 liters. And if the sugar comes down, just send her home on an insulin regimen. Right now, the oral agents aren't going to work. She may need metformin started soon, and she's already on Mounjaro, but you see the Mounjaro didn't do anything here. And if she lost weight, it was probably due to being very hyperglycemic, and she urinated out the weight. She'll need to be on basal bolus insulin for a period of time, and then things could be adjusted. But that's how I'm going to approach this lady. I think it's quicker to get her seen, get her IV fluids, get that placed, in progress. If her bicarb is low and she's in DKA, probably insulin drip. Now, the urinalysis is interesting because 2 basic urine ketones, acetoacetate and beta-hydroxybutyrate. This is the only one that tests positive in the urinalysis. So if these people are really volume depleted and they're in a low redox state, okay, you're going to have all the acetoacetate converted to beta-hydroxybutyrate, and the urinalysis will be negative for ketones, and as you treat them and as they get better, it'll become more and more positive. Now we have serum beta-hydroxybutyrate, which we're going to get also. with us. The other bugaboo, if we flush them with normal saline, they initially have an increase in anion gap metabolic acidosis. They could eventually develop a normal anion gap metabolic acidosis, more of a chloride, but that's, a day or two down the line. And I think that's all I wanted to say about this patient. Thank